My name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan. And this evening's Learn and Share conference call is entitled EEG and the Epilepsy Monitoring Unit. And we're very pleased to have with us Dr. Amer Aboukasm, who is an epileptologist with St. John Providence Health System, and Judy Ahn Ewing, who is Administrative Director of St. John Providence Health System's Comprehensive Epilepsy Program. So if you could just each give us a brief overview of your clinical and research interests and your experience with this topic, that would be great.
Thank you, Russ, and good evening and welcome to everyone that took time to join us this evening. My primary background is in neurodiagnostics, and that includes not just EEG and the EMU, but also evoked potentials, intraoperative monitoring, and long-term monitoring. And my experience has primarily been in the establishment and management of both pediatric and adult epilepsy monitoring units and coordination of comprehensive epilepsy programs. I have a special interest in the epilepsy monitoring environment with a focus on developing multidisciplinary care teams and creating a culture of safety that engages everyone on the care team and patients and families that we serve in our comprehensive epilepsy program.
Great, thanks. Dr. Aboukasm?
I am a neurologist, epileptologist. I did a fellowship in epilepsy and electrophysiology. My interest is in EEG and epilepsy monitoring. I do have a research interest, and I published a paper back in the day on psychogenic seizures. I am the director of the electrophysiology department at St. John Hospital and the comprehensive epilepsy program at Providence Park Hospital.
Okay, great. So let's start off with a basic question. What is EEG? What exactly is it measuring? What does it stand for? How does it work? What does it show?
EEG stands for Electroencephalography. It's a technology that records the brain activity in real time, recording the electrophysiologic activity of the brain. It is a simple, relatively simple technique to measure the brain activity, and it reflects in an instant the level of activity of the brain as far as if the brain is in seizure or if the brain is sick. We call that condition encephalopathy, or if there are focal area of the brain that are dysfunctional, that can be also reflected on the brain waves we record during a EEG test.
Great. And so what are some of the key signs on an EEG that an epileptic seizure has taken place? What types of abnormalities are you looking for?
Yeah, if someone had a seizure while recording the brain waves, there would be abrupt change in the background recording. The brainwave has a normal rhythm that is predictable and visible when we look at a screen or on paper at the waveforms of the brain. During a seizure, there would be an abrupt change in that rhythm. In a way, the rhythm becomes suddenly disrupted as far as rhythm becomes either faster, typically faster, in one area or in both or several areas of the brain simultaneously. And it shows a predictable evolution, we call it, meaning a rhythm becomes slower and of higher voltage, and it has a very specific pattern that helps us identify that the brain is having a seizure during that period of time. These events are sometimes very subtle and difficult to decipher, and that's our job to train to recognize them. They are of certain duration. Typically, a seizure goes from 20, 30 seconds up to 3 minutes in duration in general. Some obviously can be much longer, and the person would be in a state of seizure. We call it status epilepticus. Luckily, it's not that common unless the person is in a crisis. A seizure event typically would end abruptly, and following that ending, there'll be slowing of the brain waves, and it will be time, sometimes minutes and sometimes hours, before the brain returns to its normal rhythm that we have seen before the onset of a seizure.
Okay. And can you explain what two commonly used terms in describing EEGs are spikes and waves? Can you describe what those refer to?
Again, the normal rhythm of a brain is sinusoidal. It's a smooth, lower voltage, sometimes faster activities that occur throughout the EEG while the person is awake. There are other also predictable change in the waveforms of the brain during drowsiness and sleep. All this would be considered normal. Abnormal EEG pertaining to seizure would be the occurrence of a sharper waveforms that we look for, and they can be narrow and tall in size. And we give them different names. We call them spike when they are very thin and narrow. We call them sharp waves when they are a little wider. In a typical discharge of epilepsy form discharge, we call it, there will be a slow wave following that pattern of a spike or a sharp wave. And that would give us this is basically the signature of an epilepsy form abnormality, confirming that the person is prone for seizure or person is having seizure if this is recorded during a seizure event.
Okay, great.
Okay. From the technologist perspective, in most instances, our epileptologist, our EEGer that's reviewing the data, is not present when that information is acquired. So it's incumbent on the technologist, if they begin to see a change in the electrical activity that's being recorded, if they see frequent spike discharges or a buildup in faster frequencies, that they are making detailed observations of any behaviors that are evident in the patient that's happening at the same time, and as well being certain to maintain a safe environment, safe surroundings for the patient in the event that they do have a seizure or that the pattern evolves into a full clinical event.
Okay. So can you describe the different types of EEG, how they differ and what they're used for?
You know, most individuals, if they're being evaluated, whether it's for epilepsy or some other type of neurological question or event, would have a standard EEG that is typically about 20 to 30 minutes. And the yield in a standard EEG is very low, and Dr. Aboukasm can probably speak to specific percentages. But for the most part, that's going to be, you know, essentially will be a normal EEG. From that point, we may then suggest, or the neurologist may suggest, an ambulatory EEG with or without video, and that would be electrodes that are then applied to record EEG outside of the laboratory setting, outside of the hospital, to a small data recorder that the individual would wear overnight at home, 24, 48, up to maybe even 72 hours. and an attempt to capture a typical event in their normal environment. Again, that may not yield the information that's necessary, and maybe perhaps it does. The video EEG monitoring in an epilepsy monitoring unit allows us to use video EEG in a continuous fashion to evaluate a typical event, to be able to see physical behaviors before, during, or after each event that can also provide clues to the origin and the classification seizures. And it's in a more controlled environment.
Right, right. Do you find that there are cases where people are able, you have more success having a seizure or recording a seizure through an ambulatory EEG because people are in their normal environment? Is that ever the case, or is it usually more likely to get one during video EEG monitoring because you're able to do things to try and provoke a seizure?
I think it's twofold. I think, as you mentioned, Russ, it's a more controlled environment, and we can use provocative techniques. But we also have an ability then to, because it is a controlled environment, we generally see that the quality of the data that's collected, the actual EEG signal, is of better quality in the EMU than it may be in an ambulatory setting.
Okay. And can you talk also about, just briefly, about some of the different types of pre-surgical EEGs, like using depth electrodes or electrodes right on the surface of the brain?
Certainly. Dr. Aboukasm?
Yes. Individuals come to the EMU for various reasons, and we'll be talking about that shortly. For patients who have medically intractable seizure, we bring them into the epilepsy monitoring unit to try to study the type of seizure and where the seizures are coming from. And we do record the brain waves similar to any EEG, where we put electrodes on the scalp and monitor these seizures in like regular epilepsy monitoring unit. For those who would require further evaluation to pinpoint exactly where the seizures are coming from, because we don't have enough information from the scalp recording, we do have surgeons who would intervene by implanting electrode on the surface of the brain and in the depth of the brain. And the person go back to the epilepsy monitoring unit with their head covered with bandages, and we have electrodes coming out of the head, recording directly from the surface of the brain, giving us much more information on where the seizures are coming from, and allowing us to map out the brain to localize where the eloquent areas of the brain, guiding the surgeon where to perform a resection. So there are different types of evaluation when it comes to performing epilepsy surgery. And we call the first evaluation before the surgery, before opening the head to put electrodes in, we call it phase 1 evaluation. When it gets to a point where we need more information, it's called phase 2 evaluation with implantation of subdural electrodes, grids, and depth electrodes.
Okay, great. So if a patient has a seizure while an EEG is being done, then those findings would be referred to as ictal EEG, and ictal means seizure, so or during a seizure. And in many cases, though, as you mentioned, the yield is very low. For standard EEGs, you often don't have a seizure, and you may not have any findings. So if the patient doesn't have a seizure during the EEG, sometimes what you're forced to look for then is interictal or between seizure abnormalities. Can you explain what interictal abnormalities look like, what they tell you, and what types of epilepsy they tend to be associated with? Are there, certain types of epilepsy that are more likely than others to have interictal abnormalities?
Back to the yield, an EEG test done on someone who has seizures can be normal 50 to 60%, and sometimes even more percent of the time. Like 60% of the time, if you perform an EEG on someone who has definite seizure, you would see normal EEG. However, in 30-40% of cases, the EEG would be abnormal, giving us an idea what type of seizures the person has and where the seizures are coming from by recording what we call the interictal epileptiform discharges. And what these consist of are abrupt disruption of the normal rhythm of the brain by recording a taller and spiky looking waveform that's followed by a slow wave typically. These are, like I said, the signature of epilepsy, and they can give us also an idea what type of seizure based on whether they are localized or whether they are generalized, meaning having bilateral occurrence on both sides of the head. Typically, seizures which are of genetic nature would have generalized epileptiform discharges, and these tend to be easier to detect, or the yield of a routine EEG of 20-30 minutes recording would give us high yield at capturing such abnormality, confirming the clinical impression of a generalized epilepsy or genetic form of epilepsy. Still, although the yield is low at capturing those abnormalities, meaning 30-40% of the time, still it is very important to perform a routine EEG because it gives us enough information that we can get from a very simple test. As far as capturing a seizure during a 20 minutes of recording, it is the yield is extremely low. It's very rare to capture a seizure during a small time sampling of the brain waves. And for those reasons, we go into longer recording and longer sampling of the brain activity.
Okay. So idiopathic generalized epilepsies or generalized epilepsies that are genetic in nature have a higher likelihood of having these interictal epileptic discharges?
Correct.
Okay.
Definitely.
Okay. So if someone has been seizure-free for a significant amount of time, let's say 6 months to a year, but an EEG shows these interictal epileptiform discharges, how does that impact prognosis, treatment decisions, whether or not the individual should drive? I guess how much does the EEG play into your treatment decisions as compared to just actual clinical findings, or how often people are having seizures?
If the person is on medication and exhibiting no seizures and the EEG still show epileptiform discharges, it tells me that this person is more prone to have seizures if we ever decide to take him off the medication.
Okay.
So this would definitely impact on the decisions of treatment and long-term use of antiepileptic drugs, and probably in a way on the prognosis as whether this person will be seizure-free off medication in the future. As far as impact on the driving or the whatever occupation the person decides to perform, the interictal discharges would not have any impact on those decisions or on the driving. They do not mean that the person is having a seizure when we capture epileptiform discharges as we describe them.
Okay, great. Is EEG used in diagnosing any other conditions besides epilepsy, and how so? Just briefly.
We do use EEG for various reasons, typically in a hospital setting when we have individuals who are confused or lethargic or obtunded or in coma even. to tell us what's the state of the brain at that point. At times we use the EEGs also in our clinics in an outpatient setting for other reasons than epilepsy, in evaluating individuals with cognitive dysfunction, such as dementia.
Okay. And specifically epileptiform discharges, are those found in other conditions besides epilepsy, or if you have epileptiform discharges, is that most likely?
The epileptiform discharges would be typically seen in epilepsy situation or seizures or subclinical seizure individuals who have status epilepticus that could be not visibly seen clinically other than person being confused or obtunded. That would indicate, if you see epileptiform discharges, this means the person is having seizures or is prone to have seizures. But for the rest of the possibilities I mentioned, the brain would be slow either in a generalized fashion or in a focal fashion.
Okay. So what are the various reasons why someone would have a stay in an epilepsy monitoring unit? We mentioned pre-surgical evaluation, but what are some other reasons that you might go to that next step of going to a stay in the epilepsy monitoring unit?
Primarily for event identification. If there's some concern about, is this a seizure, is this a psychogenic event, and further then following that event identification, classifying that specific type of epilepsy and where that characterization is medically necessary in order to determine the most appropriate therapeutic treatment. Also, for those individuals who perhaps had a first-time event and it's uncertain of what that event was, differentiate between, is it a seizure, is it syncopal event, was it cardiac in nature, or did it originate with something in the brain? And then with those, as we've mentioned, with those patients that may be looking at a pre-surgical evaluation, we're going further than identification, classification, and localizing where that seizure originates in that individual, and if that, with that location, is that individual a potential candidate for surgical treatment.
Okay.
In addition to what Judy just said, we do bring patients also to the epilepsy monitoring unit to adjust their treatment or to make changes. Hello?
Yep. We just
to make changes. To make changes in their therapy, which sometimes cannot be done easily in an outpatient setting. So sometimes we bring the patient in, we abruptly drop a drug and start another drug, and this cannot be done in an outpatient setting because there are risks of having side effects or increase in seizure activities. And we do have a controlled situation, controlled environment where change in medication and adjustment of therapy can be done safely.
Okay. And can you provide an example of when that might be done as opposed to slowly weaning someone off of medication?
I do have a patient who will be admitted in the next couple of weeks where he has been for a long time on a couple of antiepileptic drugs and tried several and failed, and I'm planning to bring him in to start him rapidly on a newer antiepileptic drug while taking him some other medication which are not very compatible with the new medicine I'm planning on initiating.
Oh, okay.
That would be much easier to perform such change and such switch in the EMU while I'm also studying the type of seizure this person has.
Right. Okay. So if a patient is well controlled with medication and their diagnosis is fairly unambiguous, is it ever justified for that patient to request long-term EEG monitoring? Like, say, if they wanted to know more about what type of epilepsy they have, or if they want to know more about their prognosis, or maybe if they're considering weaning off medication, or if they're considering driving. Is it reasonable for a patient to request that if their seizures are well controlled and their diagnosis is clear?
It's not usually a typical indication to bring a patient in,
right.
but
no, and typically the video EEG monitoring is not considered a medical necessity.
Right.
If the cause of the seizures and the specific type of epilepsy is known. Mm-hmm. And in most of our, and I know we are working our way towards the discussion of insurance providers, but insurance companies consider these to be monitored with routine outpatient or ambulatory EEG, unless, of course, as in the instance that Dr. Aboukasm just referenced, right. that we document that in this particular case, this is a high-risk medication change, or there's some underlying change in the events that requires real-time monitoring.
Okay. So for some of those situations I mentioned, it would probably be reasonable instead to request a routine EEG, like
yes.
if you were considering weaning off medication, for example.
That would be the first point of entry.
Okay. All right. So you mentioned insurance. So is a stay in the epilepsy monitoring unit typically covered by health insurance?
It typically is, however, with the caveat that all of our insurance providers, say for Medicare, view an epilepsy monitoring admission as an elective procedure that needs to be pre-authorized, and therefore the insurance company will ask and expect that between the referring physician and the facility that's providing the diagnostic procedure, a copy of prior investigations and documentation of which procedures have not resulted in a diagnosis before considering an admission approval. And that would include providing information and reporting around a standard EEG, a 24, 48-hour ambulatory. Perhaps they may ask for an MRI or a brain CT if those were done, and also a current clinical notes with the neurological examination. If a patient has had an EMU admission in the past year, that insurance might also ask for detailed documentation and justification about why a second admission would be necessary. And that certainly could include that this individual has now been identified as a surgical candidate, and therefore we're going to be doing more intensive testing, or that there's something about their seizures that have changed. And it's important that between the referring physician and the epilepsy monitoring unit and the staff that we stress the justification criteria when requesting these authorizations. And we work very diligently with the referring physician and the primary care physician as well, because many times they are the gatekeeper for that patient's insurance provider. On average, we are seeing that a routine request for an admission as it goes through that process with an insurance provider is about 7 to 10 business days to have that completed. I will say there's no authorization that's required for admissions for patients with Medicare.
Yay, Medicare. It's good to hear. Okay, great. And are there options for uninsured or underinsured patients who can't afford the out-of-pocket costs associated with a stay in the epilepsy monitoring unit?
I mean, I can certainly speak for our organization that we have a patient advocate office that will work with the referring physician, the patient, and their family to be certain to provide those necessary services and make that available to them, as well as with Healthy Michigan plan for us, work towards getting them enrolled in some type of insurance plan.
Right.
Going forward, particularly if we're looking at an individual who is being considered as a surgical candidate, and they have a lot of diagnostic work up ahead of them.
Exactly. Yeah. Okay. And so what are the various approaches that the EMU team uses to try and provoke a seizure, and then how do you balance the need to capture a seizure with the risk of status epilepticus or seizure-related injury?
You know, I would stress that the pre-admission process and the communication with the patients, the family, the caregivers, and our team is critical. It is key to not only the success of the monitoring session itself, but maintaining the safety of that individual while they are in the monitoring unit. We'll take a detailed history, and along with the epileptologist and the patient, family, and our staff, develop an individualized plan of care for that patient during their admission. And in taking into consideration the semiology of the typical events the patient has, are there any triggering factors that will provoke an event? And is it something that we can replicate in the monitoring unit? And certainly one factor may be that we are, with physician directive, we would be tapering medication or withdrawing medication. Sleep deprivation may be a provocative technique. We may also have a recumbent bike brought into the unit, and exercise may be a provocative technique that would be used. And in all those circumstances, there would be emergency protocols in place for that patient in the event they do have a seizure, and the provocative technique would be in the presence of the EEG technologist, the nursing staff. The patient would not be isolated. And in addition, most EMUs will have an alarm system in place that can be triggered either by the technologist if they see changes electrographically, by the nursing staff at the bedside, or the patient or family if they have a warning aura that they can identify in advance of their seizure. We also have bed alarms on the bed itself, so if there's any movement when the patient gets out of the bed, that will alarm and alert the staff that individual needs our immediate attention.
Okay, great. And for the patient who's in the epilepsy monitoring unit, there's typically a button that they can press if they suspect that they're having an event, or the family can press it. How often is that incorrectly pressed, or I guess, because some simple partial seizures, for example, can be very subtle, and say someone is just feeling vaguely dizzy or something, they may press it, but it may not actually be a seizure, it may be unrelated. I guess, how do you counsel patients in terms of when to press that button? We would rather have more events identified from the patient perspective. We're looking at what they believe is a typical event, what they believe are recognized as their symptoms that we're attempting to distinguish. There may be times that they're pressing the button, and as you alluded to, Russ, it is not accompanied by any electrographic change, but just as often as Dr. Aboukasm can speak to, we may detect something electrographically and there is no push button on the part of the patient. There is no clinical manifestation. So it works in concert with the technologist that's monitoring electrographically and also behaviors, as well as the patient reporting their symptoms, and if there's a family member in the room, what they
will recognize as being the typical event that is of concern to them.
Right. Okay. So what are some tips to help individuals and families make a stay in the epilepsy monitoring unit more bearable, particularly for children?
With our kids, we have a service within the facility that's referred to as the Child Life Services, and we work closely with them to engage the child and with the family on distraction techniques. They encourage the families to bring any comfort items that the child, that's special to the child, any games, books, puzzles. If it's during the school year, then the child life specialist will contact the school and also coordinate any school activities that we can continue in the monitoring unit even while the child is undergoing diagnostic testing. With the adult patient, same thing. We'll look at games, books, puzzles. We have cable TV, DVD players. We do allow electronic devices to be brought from home. However, we will, when those devices are in use, the technologist will make sure that they're not interfering with the EEG signal. And we do let our patients know that in advance, if that is interfering with the signal, then we may ask them not to use it.
Right. So,
and we also encourage our pet therapy team, if there is no contraindication, to have a visit from our pet therapy team. And Parker and Doc, our black Labradors, come and visit our patients in the epilepsy monitoring unit, and they can cheer someone up who's been sitting there for a while.
Right. Okay. So what should patients do with their hair before an EEG, and then after an EEG? How is the glue removed? And then lastly, should patients expect EEG staff to assist with glue removal, or are you kind of on your own after you get home?
Well, let's first dispel the rumor that we don't need to have a haircut and we don't need to shave any heads before you come into the monitoring unit.
Right.
But, really the key to a successful recording session and quality data begins with the contact that's made between the scalp and the electrodes. So that being said, it's really key that the patient comes with clean hair that's free of any hair products. We want to be able to have a good interface between that electrode and the scalp. And some of the application products that are used may not adhere to the scalp as well if there's hair products. So we're simply asking for clean hair, no hairspray, no gels when they come into the monitoring unit. There can be different electrode applications that are used if we know that an individual has an allergic response to a particular product or an adverse reaction in some fashion. But generally speaking, the electrodes are applied with either paste, similar to a standard EEG, or a product that's referred to as collodion. The paste is about the consistency of toothpaste, and it's water soluble, so it easily removed with routine shampoo. Collodion is a fast-drying, ether-based glue that is, when it is applied, most laboratories use a compressed air to dry that collodion as it's being applied, and it's used primarily because of its holding properties. It can maintain the electrode in place for a longer period of time, particularly, and allow the patient some more freedom to move around. Both applications can provide quality data, and with either application, your technologist will remove most of the glue recording when the recording session is completed and the electrodes are removed. and they'll do a spot wash of the scalp with the paste. With collodion, there is a specific collodion remover that is used, and it has it's a bit of an oil base. And so we generally recommend that a patient apply a cream conditioner or a rinse to the scalp before shampooing the collodion, and take a brush through the conditioner, through the hair, which loosens the residue and makes it much easier to shampoo. And those are things that we would have in the monitoring unit. Most individuals, once the monitoring session is complete and they're getting ready for discharge, one of the first things they want to do is be able to get into the shower.
Right. And so interpreting EEGs correctly, you mentioned, the importance of getting a good reading, but also interpreting EEGs correctly is really important, and relating that to the video and clinical findings, and it takes a lot of skill and experience. And unfortunately, not everyone who attempts to interpret EEG findings has the same level of skill and experience. So can you talk about why that's important, and then what some of the common errors in EEG interpretation and seizure observation are that you've seen or you've come across?
I can answer this question. Like you mentioned, Russ, there is a level of expertise and expected level of training, and experience obviously is another add more to the knowledge of how to interpret EEGs. There can be errors easily committed in interpreting EEG, frequently in relation to artifacts. The EEG records very small signal from the scalp in the microvolt range, and many factors that occur during the recording can obliterate or can look like an abnormality that would look like an epileptiform discharge, for which an EEGer needs to sort out and study and decipher what's the origin of this differently looking waveform. We see mistakes made interpreting EEGs on that basis alone, and it's not uncommon. On the other hand, there are normal patterns of EEG that look different than most normal EEGs that also need to be recognized, and a trained EEGer would be able to decipher what we call normal variants. These are not uncommon, and we see them at certain ages and certain states of the brain during drowsiness that also need to be recognized and not be labeled as epileptiform. Sometimes rhythmic abnormalities can mimic seizures. There are a lot of situations that can make changes in the EEG based on how sensitive the EEG is that may look like a seizure, and that's where we need all the information available during the recording from our EEG staff who's performing the test to give us an idea of what's going on during that event captured on EEG. It became easier nowadays with the availability of digital video recording, which is simultaneous to EEG test, to help us identify those abnormalities that may look like seizure and they may not be. Now, there are certain seizures which cannot be captured on the scalp EEG. Frontal lobe seizures sometimes are difficult to identify. They can result in very subtle changes in the normal background of an EEG test, and that poses another level of difficulties for us EEGers to sort out.
Okay, and certainly something that we hear a lot of is people either being misdiagnosed either as having psychogenic non-epileptic seizures or as having epilepsy when in fact they do have psychogenic non-epileptic seizures, or someone being told that they have psychogenic non-epileptic seizures without having any kind of video EEG confirmation. Is that something you encounter, or can you talk about the importance of video EEG in making a definitive diagnosis of psychogenic seizures?
Actually, video EEG is the gold standard to confirm the presence of non-epileptic seizures, which can be psychogenic, which can be also related to physiologic changes in the body, related to heart problems or metabolic changes up in the blood sugar. High blood sugar can cause changes looking like seizures, but they're not necessarily epileptic. So the video EEG, the recording of the brainwaves simultaneously to the clinical manifestation on video camera, confirm and is used as the gold standard to confirm the nature of a seizure event, which could be epileptic or it could be non-epileptic or psychogenic. And I can attest to myself, in my experience, I was fooled looking at patients who fooled me as far as their seizures could be psychogenic, and I was mistaken until we put them on the video camera and studied by simply looking at the patient, you cannot always be sure. By looking at the EEG itself without the video, you cannot be sure neither. Sometimes genuine seizures can look like epileptic on EEG. Well, you need the clinical confirmation to figure out what's going on. So definitely we need both capabilities to confirm what's going on and to figure out what's going on.
Okay, great. Are there any special qualifications that patients should look for in their neurologist and their neurodiagnostic technologists that will increase the likelihood of an accurate EEG testing and interpretation?
As Dr. Aboukasm alluded to, there is, in tandem with the level of expertise and experience that comes with working and staffing in an epilepsy monitoring unit, there are special qualifications and competency assessments both for physicians and technologists around clinical neurophysiology, which would be the EEG interpretation, and around epilepsy specifically. An epileptologist is also a board-certified neurologist, but a board-certified neurologist is not necessarily an epileptologist as well. So that within that discipline of neurology, our subspecialties in epilepsy is one of them. Clinical neurophysiology is one of them. And yes, there are board certification exams for physicians in both clinical neurophysiology and epilepsy, and as well for the technologists, there are credentialing exams for the EEG technologist, and then further specializing would be the technologist that has certification in long-term monitoring for epilepsy, and that is the registered EEG and or the CLTM credential. In addition, there is an organization, the National Association of Epilepsy Centers, that recommends guidelines and criteria for epilepsy monitoring units and for the qualified personnel, and does define criteria that would designate an epilepsy center as being a level 1 or a level 4 center. And in very general terms, a level 3 center would do non-invasive evaluations, and they may or may not offer surgical treatment for epilepsy. Your level 4 center is either a regional or a national center that can provide more complex forms of monitoring, as we spoke about earlier, those invasive intracranial electrodes and/or depth electrodes, and offers a much broader range of comprehensive services. And so those are questions that you would ask of your facility when you're being referred. Will I be monitored 24/7? Who is doing that monitoring? Is it a technologist? Is it nursing? And what is their level of expertise? And is this a level 3 or level 4 center?
Okay. And with clinical neurophysiology, I've noticed in trying to learn more about various neurologists, there are different types of clinical neurophysiology fellowships, right? There's some that are EEG epilepsy tracks, and then there's others that are, is it EMG or a different track? Can you describe that distinction? Because sometimes clinical neurophysiology doesn't necessarily mean EEG and epilepsy, right?
Right, that's correct.
Okay. So have there been any recent advances in EEG technology or practice that are, or any that are on the horizon that people should be aware of?
Luckily, EEG changed from being an analog recording 15, 20 years ago. In the 90s, we started seeing EEG equipment turning into digital equipment. And that made a huge forward leap in what we can do with EEG and how long we can record EEG and how portable EEG recording devices are. So we became able to record EEGs on the run in someone who goes to work or to school by just fitting them with devices. And the capability and the number of channels recorded is amazing, and the quality is great. So that's a huge improvement in the EEG technology that we have seen in the last 15 to 20 years. In addition to better recording and easier recording of the brainwaves and acquisition of the data is the reviewing. We can review tests from any point in the world as long as we have access to internet in today's age. And we have also the capability of storing this data in a much easier fashion than what we used to have available back in the days. As far as newer stuff coming to the horizon, there's a new technique now used for individuals who are undergoing epilepsy surgery, using depth electrodes that are implanted through the skull instead of doing a craniotomy. We can guide and introduce small, thin electrodes in various areas of the brain, and sometimes many of them, up to 15 or 20 electrodes on either side of the head, to record the brain waves in a minimally invasive fashion, avoiding potentially a craniotomy, like I mentioned earlier, as phase 2 evaluation for epilepsy surgery. This is newer and started to be used in the last couple of years, and I see this field is going to mushroom in the near future.
So, and a craniotomy is opening of the skull, correct?
Correct.
Okay.
So avoiding a craniotomy, doing pre-surgical evaluation by introducing electrodes through the skull directly into the brain with minimal pinhole, practically speaking, to record the brain waves before surgery is decided on.
Okay.
Which surgery would require, obviously,
right,
a craniotomy ultimately.
And you mentioned having more channels now. What exactly does that mean, that you have more channels?
Recording in more area of the brain and with higher definition by adding more channels, meaning more electrodes to the head.
Got it. Okay. So how far away are we from having some sort of commercially available wearable device that uses EEG to detect seizures and then alert either the person with epilepsy or caregivers?
There are devices out there being tested. I am not aware of commercially available stuff that we can order right now for any individual to wear and use as an alarm bell for parents or for family to tell that the person is having a seizure. There's a new device, a brain stimulator that was approved by the FDA 2 years ago called NeuroPace. It is a device that would be implanted in the skull that would detect seizure and stimulates the brain when a seizure is detected in order to suppress the seizure activity and abort a seizure. Such device is available, and it's preserved for individuals who have medically intractable or medically refractory seizures, and if they are not candidates for resective surgery of the brain. And this is based on a technique that detects seizure and stimulates the brain in response to the seizure detected.
And it seems like that software could be adapted to, communicate with a smartphone or something when a seizure is detected, so that the smartphone could then coordinate or contact family members to let them know that the seizure has been detected by the device. Have you heard of whether that's something that they eventually plan to do to adapt the device?
I am not tuned to such technology, but it is amazing what's out there available and how flexible technology and our portable devices we're having nowadays. Won't surprise me if we hear in the near future of something.
Okay.
So, Judy, have you heard of anything?
I haven't specifically. I have heard of conversations around that as well, but that it would be something, as Russ indicated, once we've got the ability to detect that onset and then being able to communicate that is probably the easy step.
Right. So before we open it up to questions, do either of you have any closing thoughts on the topic that you'd like to share?
I do think we covered most of what can be covered. I'd like to hear from our listeners what their questions and whether we need to clarify any of these points.
Sure. Okay, so I'm going to go ahead and unmute everyone just a second here. Okay, who would like to get us started with a question or a comment?
I'll go first, Russ. This is Dawn Esparza.
Okay.
Hi. My son is 6.5. He has first seizure at the age of 3. They are benign occipital seizures. He's been seizure-free now for 2.5 years. He's only had 5 in his life, but he's been to at Children's Hospital at the overnight EEG, the 23-hour video monitoring EEG. We did one November, and this was after he had been seizure-free for 2 years. And his neurologist said that they're still seeing abnormal results. They didn't capture a seizure, obviously, but they suggested that we keep him on his meds for another year and do another 23-hour EEG. He's had 2 so far. So we're going to do a 3rd one in November. Hopefully, things will balance out and he'll be able to come off his meds. He's taking Keppra and Trileptal and doing great on them. What will we find in November on our 3rd 23-hour video monitoring EEG that will hopefully get us to the point of, okay, we can start taking him off his meds? What will that EEG tell us?
Your son is 9 or will be 10?
No, he's 6.
Oh, he's 6. Yes. Again, like I mentioned earlier, we do use this, what we call recording of EEG, to capture interictals, meaning see if the person has discharges. Luckily, your son has this benign form of epilepsy, which most likely he will grow out of it. Probably you were told that already.
Yes, sir.
Yes. And they're using the EEG as a tool to decide are we safe at this point to start weaning off the medication, to basically monitoring and trying to detect if he still has these epileptiform discharges. If they're not there, it makes the likelihood that him being off the drug better, that he will not have seizures. So it increases chances that he will be seizure-free off the medication if his EEG is normal. If he still has abnormalities and interictal discharges, his chances to have recurrent seizure would be higher being off the drugs. So they're using the tool to guide them to decide whether it's safe and when it's going to be safe to take him off the medication.
So maybe it's quite possible he'll have to have maybe a few more years seizure-free and a few more EEGs to make sure that things are balanced out, or that he has in fact grown out of it. Correct.
Yeah, typically someone who has that form of seizure, they would be typically seizure-free and in remission, and the seizures are over their epilepsy by their adolescent year or teenage, or maybe even before. So they're really trying to see if we can take him sooner.
Okay, so that the interictal discharges that you spoke of may disappear in time.
Correct.
Fabulous. Thank you, Russ. You asked all my questions as usual already. Thank you so much.
Great. Other questions?
Anybody? Hey, this is Grant Worden.
Okay.
Hey there.
Hey.
I was at the end of the conversation there. I was just going to ask about the Embrace watch that the Epilepsy Foundation is putting out there. You know, if it takes something implanted in your brain or whatnot to, you know, I just didn't hear you guys bring it up at all, and I know that it's out there. And
Right. So the Embrace watch uses primarily movement to detect seizures, but it's one of the first watches to also include other physiological measures, things like electrodermal activity and heart rate and that kind of thing as well. And it, you know, I think it can. There's a version of it that can also measure stress and sleep and things along those lines, and physical activity, so that you can correlate that with seizures. But that device does not involve any kind of implants, or it does not.
No.
It does not monitor EEG or anything like that. But yeah, that's.
But any thoughts on it, though? I mean,
yeah,
talking about EEG and electrical, you know, monitoring systems and stuff like that. What does anybody think about that? That one.
Okay.
We were talking about. Yeah, go ahead, Russ. You may have more information on this. I don't have much to say on that gadget.
Yeah, so the Embrace watches, it hasn't technically even been released yet. They're going to begin shipping them in October, I believe. And this is a device. Some of them have been made available for free to Epilepsy Foundation, the national office, so people can apply for that. So as far as people having experience with it to share, I don't think anyone has actually used it yet, unless they happen to be on the original trial that studied that. But has anyone else had, in a related question, has anyone else on the phone had any experience with any kind of seizure monitoring or alert devices, like the smartwatch or the bed monitors or anything along those lines?
I had the vagus nerve stimulator. Have you guys heard that? Yeah.
Okay. Yeah. So the vagus nerve stimulator is a device that periodically provides stimulation to the brain via the vagus nerve. It doesn't do anything, however, to detect seizures or alert others to a seizure happening. But it does come with a magnet that can be used if the person with the VNS has an aura or a simple partial seizure, they can swipe the magnet across the device. Or if someone else notices that the person has already started having a seizure, they can swipe the magnet across the device, which delivers a higher level of stimulation and can sometimes shorten or stop the seizure. But has anyone used any of the devices, the seizure detection or alert devices that often work with a cell phone or have an alarm associated with it?
Hey, Russ?
Yeah.
This is Karen Gooding. I beeped in late. Yeah, down here in Monroe County, as you know, I work with people with epilepsy. I have two people that do have those house monitors. They also wear them on their wrist or around the neck. They don't have any signs of seizures, but when they really they do beep for paramedics, and most of the times they do go into seizures.
Okay.
So we are aware of it quickly.
So that's another type of device that is that can just be if you sense the seizure is coming on, or you can press a button that will alert whoever you want it to alert. And there's some that also have a fall detection system that if you fall, it will automatically alert someone. Other ones are based on movements associated with tonic-clonic seizures. Some are based on movements in a bed. Some are based on video recordings of movements. So there are many different devices out there. But as of now, there are none that I'm aware of that actually, other than the NeuroPace, that actually
The NeuroPace, right?
That actually measure electrical activity in the brain. And it seems like that would be probably the quickest way to be able to come up with an alert system. It would be to somehow modify that device for people who have it, at least, so that it can alert others when a seizure is detected. But I guess we'll have to try and get the creators of NeuroPace on the phone to talk about whether that's in the plans for the future. Other questions or comments?
Russ?
Yep.
This is Karen again. My cousin is over here, Beth Young, and she wanted to know if she could ask a couple questions about being able to tell the funny feelings that she's having, whether or not she can tell if they're seizures or non-seizures. Okay. But I am going to put her on the phone.
Sure.
Okay. On the speaker.
Hi, this is Beth Young. I was just recently diagnosed with non-epileptic seizures because I go into spells, but half the time I don't know when they're going to start or anything. Is there a way that I could figure out on how I know if I'm going to have a spell or not?
I'll take this question. Okay. It is non-epileptic seizures. They are similar to epileptic seizures. They're unpredictable, but there's sometimes a pattern to their occurrence, and they tend to occur when the person is stressed out or in a certain situations of stress and a lot of things going around you. But this is not necessarily the case. They are unpredictable, and it's not possible to determine whether today or next week or next month you're going to have another one. And treatment will hinge on you having counseling and proper evaluation, and I presume your diagnosis is correct based on the evaluation of your doctors. So you need to work with your counselors, neurologists, and psychologists who are specialized in this field of non-epileptic psychogenic seizures?
I am seeing a neurologist right now, Dr. Andy Zilgett, and I just started filing for disability, and they want me to keep track of how many spells in that I have, and half the time I don't even know if I'm having one or not because they just come and go within seconds. So I have a hard time deciphering whether if it was a spell or if it was just stress and due to my husband's cancer and everything, because my husband has brain cancer.
I see. Well, let me reassure you. You're working with a top-notch neurologist, epileptologist, and you're working with a wonderful team where you're going. I'm sure you'll find the proper help where you're at in the Ford system. I know Dr. Zilgett very well. And I'm sure you will do well. People who have non-epileptic seizures, they are very healthy individual physically, and you will do better with time. Time will take care of the problem and success with proper counseling.
Okay, thank you.
Excuse me. I say it would be good to write to see, you know, what you say, doctor, when you have one, it'd be good to write it down, what happened and everything. Then when you go into a doctor's office, you get your paper to the doctor, and the doctor see everything, they can read, you know, what's going on and everything, and know what to do, you know, something they haven't done and everything, take care of it, no problem.
Right. I think that the process of keeping, excuse me, a seizure diary or journal is really important, and when in doubt, similar to what we were discussing before with whether to press the button or not when you're in the epilepsy monitoring unit, I think it's better to have more episodes written down even if you're not sure if it was actually a seizure or a non-epileptic spell. So I think it's important if you have something that was unusual and you're not sure what happened, and it was a discrete episode that was different from your normal behavior or your normal situation, then to go ahead and make a note of that, to write what happened during it, what happened before, what happened after, in as much detail as you can, and that will be then the job of the healthcare team to be able to sort out whether that was an event or not. And the more you journal, the more you share that with your health care team, the more you'll start to recognize your episodes and what is one and what isn't. Okay. Other questions or comments?
Excuse me.
Yep.
Can I ask the doctor something?
Sure.
Well, I know, see, so you got implant thing on your brain, and you can tell when the seizure's coming on and stop it. And then also, see, because I had the V in Las Vegas neurostimulator. And then which one is the best between those two?
Thank you for the question.
You're welcome.
You're talking about the vagal nerve stimulator or the implantable stimulator within the head.
Correct. I'm talking about both. But one was the best.
Apparently, the results are similar, but there are different people who have seizures that are clearly localized, well-defined where they're coming from two parts of the brain, from right and left. Individuals like that, they are not good candidates for resective surgery to remove part of the brain that's causing seizure. Those seem to be proper patients to have this implantable device in the brain called NeuroPace. As far as which one is going to give us better results, the results are not much different than the vagal nerve stimulator, which again, nothing is 100% in this kind of field of treating people with medically refractory seizures. So any benefit looking at 30% improvement, which is what's out there published, is nice advancement in controlling someone's seizures. And we still go through that hassle of planting inside the head devices that may work. But there has not been stunning results to tell us that's the answer for everyone.
Right.
It depends on the individual, what device would be more proper for a person.
Okay.
Mm-hmm.
All right. Well, we are actually out of time, so appreciate everyone participating, and thank you so much, Judy and Dr. Aboukasm, for your time and for sharing your expertise. And I hope everyone learned something new today. And the recording, if you want to go back to refer to this or share it with anyone else, the recording should be on the website by probably Tuesday of next week. So, okay, thanks everyone.